A 14-year-old boy presents with progressive thigh pain that is characteristically worse at night and relieved by ibuprofen. I'm showing you the radiograph of the femur. Describe the findings.
Okay. The radiograph demonstrates a focal area of dense cortical sclerosis and periosteal reaction affecting the shaft of the femur. Within this dense bone, there is a small central radiolucent focus measuring less than 1.5 centimeters, which is consistent with a nidus. The surrounding reactive cortical thickening is extensive. These features in a young patient presenting with nocturnal pain are highly typical of a cortical osteoid osteoma.
What is the differential diagnosis for this radiographic appearance, and how do we differentiate between them?
The primary differential diagnoses include localized osteomyelitis, or Brodie's abscess, and eosinophilic granuloma. A Brodie's abscess typically presents with localized inflammatory signs, fever, and elevated inflammatory markers. Radiographically, it exhibits a serpentine lucent tract extending toward the growth plate, and T1-weighted MRI demonstrates the penumbra sign of a hyperintense inner border. Eosinophilic granuloma is characterized by a more aggressive-looking permeative lytic lesion with laminated periosteal reaction, but lacks the profound dense reactive sclerosis seen with an osteoid osteoma.
I am showing you the corresponding computed tomography reconstruction of the femur. Describe the findings and explain the diagnostic value of this modality.
The CT reconstruction clearly demonstrates the small, well-defined oval radiolucent nidus centered within the thickened sclerotic cortex of the femoral shaft. Computed tomography is the imaging modality of choice for osteoid osteoma, as it easily identifies and localizes the nidus, which may be obscured by the dense surrounding sclerosis on plain films. CT confirms that the nidus is well-defined and may contain a small central calcification, allowing for a confident diagnostic distinction from infection.
Discuss the different types of osteoid osteomas based on location, and detail the scintigraphic appearance.
In that case, osteoid osteomas are classified into three types: cortical, cancellous, and subperiosteal. Cortical lesions are the most common, classically involving the diaphysis of long bones. Cancellous lesions frequently target the femoral neck or posterior spinal elements, presenting with mild reactive sclerosis that is often distant from the nidus. Subperiosteal lesions are the rarest, producing a soft tissue mass immediately adjacent to the bone rather than sclerosis. On isotope bone scintigraphy, osteoid osteoma demonstrates the characteristic double density sign, where a small area of intense radionuclide activity in the nidus is superimposed on a larger area of moderate tracer accumulation from the reactive sclerosis.
How would you manage this patient as a radiologist?
Well, as a radiologist, I would recommend comparing these images with any prior radiographs to confirm the chronicity of the cortical sclerosis. Since radiographs are highly suggestive, I would recommend obtaining a dedicated thin-section CT of the femur to precisely map the coordinates of the nidus. I would promptly communicate these diagnostic findings to the referring orthopedic team. Finally, I would recommend referring the patient to interventional radiology for CT-guided radiofrequency ablation, which is the modern standard of care and has a success rate exceeding 90%.